Before we get too into today's programming, I'm just going to talk a little bit about our land acknowledgement and go into that first. So I'm sure as many of you folks know, Toronto is in the dish with one spoon territory. It's a little bit tricky to do land acknowledgements, right, in this age of Zoom, because where I'm located could be vastly different from where you're located. So Maddie's going to put a link in the chat, native-land.ca. So if you're unsure of whose territory you're on, feel free to head over to that link and it should give you all of that info. Also, fun fact, I never know that Maddie's going to put the link in the chat, but I always know because it's always there without fail. So thanks for that, Maddie. But as I was mentioning, Toronto is in the dish with one spoon territory. The dish with one spoon is a treaty between the Anishinaabe, the Haudenosaunee, and the Mississaugas that bound them to share that territory and protect their land. Subsequent Indigenous nations and all newcomers have been welcomed into this treaty in the spirit of peace, friendship, and respect. For a lot of us who are familiar with Ryerson spaces, I'm sure we've kind of heard this land acknowledgement before, right? But do we kind of know what that means? So when it refers to the idea that Toronto is in the dish with one spoon, it refers to the idea that this land is all known as Tukaronto, which is a Mohawk word for where the trees meet the water. Was a very naturally rich resource area, right? As I'm sure you can imagine before all the concrete and colonization, right? Um, and because of that, and because the area was so naturally rich in resources, several different nations, right, the ones that I mentioned, would all kind of share and eat out of that same dish and eat out of the same land, which is the reason why it's the dish. And the reason why it's the dish with one spoon is because I am not sure about you folks, but when I look around my dinner table, right, the spoon's usually the least threatening option. So it's really to symbolize that coming together in the spirit of peace, which is that second part of that treaty. So I hope that explains things a little bit better today. And as we move into the programming, I think it's important that we reflect on the ways colonialism impact things like harm reduction, right? And kind of when we have some of these conversations about what harm reduction means, about some of the conversations we'll have today around prohibition and the war on drugs, right? Making sure that we're considering the ways in which colonialism kind of plays into all these systems, if that makes sense. But I'm going to start sharing my screen so we can get into some of the actual programming for today. A lot of the content that we'll be talking about today can, for various reasons, be triggering, right? When we talk about racism, when we talk about incarceration, when we talk about life loss due to overdose, some of those things can have a bit of an emotional toll, right? So some of the things that we're going to talk about today are going to cover kind of what harm reduction is, how to physically use naloxone and where to get it, where kind of the war on drugs originates from, and about kind of the racist history of prohibition and why prohibition doesn't work, right? But before we get into that, we're going to specifically talk about the naloxone training specifically. So I'm going to talk a little bit about the signs of an overdose, and then we're going to have Simon chat a little bit how to physically administer that naloxone. So we're going to start with if Simon's internet stays true and strong. So some of the signs of an overdose when we're talking about when we should be issuing Narcan or naloxone, right? And we use those words interchangeably. One's just a fancy longer word, one's a shorter word, right? But what are the signs of an overdose and when should we be administering this drug? I think that this is one of the things that's really important to start with. So some signs of an overdose for when you should be administering naloxone or Narcan is when the person is not moving and can't be woken. There is slow, shallow breathing or not breathing, blue lips and nails. The person may be choking, making gurgling sounds or snoring, cold and clammy skin, and the pupils are tiny. A really important part when we're talking about kind of issuing Narcan and naloxone, right, is that oftentimes people get really stressed about when is the appropriate time to administer and when's not the appropriate time to administer. But I think the most important things to kind of keep in our heads, right, is that Narcan is always a life-saving drug. It is never a life-taking drug, right? So even if you were to administer it to somebody who isn't going through an overdose, that's not necessarily going to have any serious physical repercussions on that person. So that's really important to kind of keep in mind, where if you're someone who feels anxious about, I don't know if this is the right time, it's always better to kind of err on that side of safer rather than sorry, right? I'm going to pass it off to Simon to talk a little bit about the nasal spray, and then we're going to get into injectable as well. But for now, let's start with the nasal. Simon, do you want to take it away?
All right, thank you. Yeah, so Narcan is available in injectable and nasal spray forms. Basically, with the nasal spray form, you insert the the device that you see on your screen into one of the nostrils of the person, and you press down on the red plunger, and it delivers a spray into the nostril that's absorbed and then taken to the lungs, and they will start circulating the drug. Nasal spray is good compared to the injectable form, especially if you're not someone who works with a lot of these medications regularly, uh, in the sense that you're less likely to screw it up. And that can be very good if you're under a lot of stress. Maybe it's a loved one who's overdosed, and you're you're really under a lot of pressure. There's a lot less that can go wrong with a nasal spray compared to an injection form. One thing that's important to do, though, if you're going to use the nasal spray, is you want to check for what's known as a deviated septum. Uh, the septum is the piece of tissue that it separates your two nostrils, and for some people, it will deviate to one side, and it will occlude partially one of the nostrils, and it's normal to happen. It's not a major finding, but if you're going to deliver a nasal spray, you need to just check both nostrils and make sure that it's like wide open, so that they get the full dose and that it's delivered properly. But yeah, it's very easy. You just insert it and spray.
And then maybe Simon, do you mind talking about the injectable naloxone as well?
Yeah, so injectable naloxone, it's available in all kinds of different, there's three kinds of injections you can get for it. You can get intramuscular, which is an injection into the muscle, subcutaneous, which is an injection into the fat tissue, and intravenous, which is directly into a vein. Now, intravenous would be the fastest acting because once it's in the bloodstream, it starts to act right away, as with any drug. Whereas subcutaneous and IM, they take longer to start acting, which can be good for some medications. Actually, some types of opiates will give as IM, or well, not IM, but subcutaneous injections, just so that it's absorbed over a longer period of time and you get a more sustained delivery. And there's many other drugs that you'll give subcutaneous as well, like insulin. So yeah, in terms of fast acting, you would probably want to go with IV. But part of the problem is that if someone's having an overdose, their blood pressure will go way down, and it can be hard to find a vein at that point, because a lot of the pressure that like allows it to press against the skin isn't there. So if you can spot a vein on someone, that's good. Or in the event that they already had access for whatever reason, like if you were in a hospital, they might have an IV started that you could inject it into. Then IV is the way to go. But yeah, it's really all about finding that that vein that you're going to inject it into. And that's why I said earlier, like the nasal spray is just there's fewer steps to it. You're probably not going to mess around with the fumbling with a needle or finding a vein. So that's just something to consider when you're using the IV. But on the other hand, the IV is going to be a lot faster. It's going to be rapid acting.
One thing I do want to clarify is that when you get the kits from the pharmacy and when we're talking about injectable, it will be intramuscular injection. If you're not someone who is a medical professional, please do not try to do IV injections. It can have a lot of really negative health repercussions for that individual if you miss, or if there's bubbles and what that ends up looking like. So yeah, please, if you're not a medical professional, you should not be looking for a vein. It should not be something that you're doing. And the kit that you will get will look like the kit that's on screen. So we can kind of go through the top, and I'll go through what everything is in the kit as well. And I'll explain what the intermuscular component is a little bit more as well. So if you look on the screen here, The quick saver portion has the part, and that's for when you're going to be doing CPR, right? So it's always a good idea that if you're doing CPR on someone who's maybe not breathing after you administer the naloxone, to try to use a mouth barrier if you can. And when you get your naloxone kit from the pharmacy, they will have these items in the kit as well. So don't feel like you have to go out and purchase these. Don't feel like you have to do that. Sorry, Simon, was there something else you wanted to add?
Yeah, so there's a good question in the chat from Serena Seguin. If someone is not breathing, how will nasal spray reach the lung? So if someone is having an overdose, they may still be having some respirations. Like they shouldn't have stopped breathing entirely. Usually one of the numbers we'll use is you can count a person's respirations, the breaths per minute as their chest rises and falls. And you will hold an opiate if it'll depend on the amount, but if it's below like 10 breaths per minute or 8 breaths per minute.
Yeah, Maddie.
Something I can just add here as well is that if you're administering nasal naloxone, before you do it, you're going to be tilting their head backwards. So if they're lying down, you're going to be raising their head like this. If they're sitting in a chair, you're going to be raising their head like this. Whatever you're doing, you're tilting their head up. So the naloxone is going up their nose, and in a way, it's going to be kind of going down as opposed to them breathing it in. And that's also the way the dispenser works. It has a little pressure gauge that when you push the thing, it's kind of like pushing a syringe, and it pushes the naloxone up into the nasal cavity. And then I'll just also answer Denise's question about nasal spray expiring, because there have been recent updates to the shelf life of naloxone. So it was understood for a long time that it only lasted for 24 months. But that's actually not accurate. And folks who've used naloxone know that that's not accurate, because it does work after 24 months. So it works up to 36 months. So if you can remember when you got your naloxone kit and you can count 36 months after that, it'll still be good up until then, and it'll still work. But if you want to get more kits, like I just stockpile them. And as many times as you go to Shoppers or wherever, if you want to get them for free, they'll give you a free one each time. And you can be annoying if they're slow or they don't want to give it to you for any reason they're difficult. Just be persistent and raise your eyebrows at them, and they'll give you one, and you can stockpile them.
Love the stockpiling tip. And I think, as Maddie mentioned too, you can get these things at Shoppers. And I'm going to go with, as we move on in the presentation, there's going to be a resource that'll point out all of the different places by geographic area where you can access naloxone and Narcan kits as well. But just as I kind of go through some of the things that come in this kit, right? So again, that first thing is that mouth-to-mouth quick saver, which can just kind of help if the person is sick, right? To make sure you're not catching whatever they have. It'll also come with these, It'll also come with this 5 steps to respond to an opioid overdose. So I know sometimes it can be scary, right? Because you're like, okay, I'm learning this today in this workshop today, but what if I forget? Or what if when it actually happens? So the kits do come with this helpful little guide that kind of tells you the walkthrough process. I know intramuscular sounds really scary, right? You're talking about injecting someone. Oftentimes when we think about the ideas of injecting people, we get nervous because we're thinking, again, we're looking for that vein, we're doing X, Y, and Z, right? But it's actually really, really difficult to mess up an intramuscular injection. So the places where you're going to inject an intramuscular injection is going to be, and sorry folks, I'm going to use my body as an example. So I'm going to stand up and point to some areas where you would do this. But if you're someone who's using injectable naloxone, you're going to inject someone in the top of their thigh at a 90-degree angle, in the part of their stomach here, again, at a 90-degree angle, or in the fattiest part of their butt, so like of their butt cheek or their upper arm if you absolutely need to. It is preferable though for intramuscular to prioritize thighs, just because oftentimes it's just a little bit easier. It's a big space, right? It's always easier to access someone's thigh than access someone's butt. Maybe, I don't know the circumstance. You know what I mean though, right? But intramuscular is like really, really difficult to mess up. There's no risk of getting air bubbles, like it doesn't have a huge health repercussion. There's not repercussions in terms of trying to find a vein and getting blood infections and anything like that. You're just injecting into a muscle. And as long as you're kind of on that 90-degree angle, otherwise you're totally fine. But the way it would look like is the syringes that you see in the bottom left, essentially in the naloxone bottles, will have an area either where you break off the glass top and inject it. Most of the Ontario ones have a glass top you need to break off. Or it'll look like the naloxone bottles that you see in this photo that I have up, which are these little vials, which will just have a silicone top that you just stick the needle through and pull up. You don't need to take the top off or anything like that. If it has a squishy top, you can just stick the needle in. And that's kind of a good rule of thumb. And just making sure that, of course, when we're doing anything like this, right, we're wearing gloves to make sure that we're not getting other people sick. And not giving other folks infections while we're trying to help them, and making sure that we're using these really nifty little Loris alcohol wipes that we see in the bottom, right, to sterilize the area before we're injecting that person, right? Just because you can never be too safe. One of the things that you'll notice also when you look at the 5 steps to respond to an opioid overdose on this little graphic here, at the very bottom, you'll see that there's kind of a person laying on their side. And this is one of the really, really important parts after issuing naloxone. It's a little bit trickier for nasal because like Maddie said, you're gonna wanna keep that person's head tilted back a little bit to make sure the medication is going down. But once that is done, or if you're doing injectable, making sure that you're putting someone on a position on their side. And I know this sounds kind of small, but this is crucial, 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 crucial info. So oftentimes when folks do overdose or going through that process, right, it causes you to get sick, especially as you're coming out of it. You're likely going to throw up. And oftentimes what we see is avoidable deaths because people are left on their back, they're throwing up, they're choking, and then they're passing away another way. So a really important step is just making sure that you're putting folks on their side with one arm under their head like this, and their top leg kind of balancing, right? So you're making it in a way that they can't really roll back over, right? Because their weight is propelling them down to that side. Does that kind of make sense for folks? Cool. Yes, and good point, Maddie. You don't need to cover the other nostril when you're injecting it. At that point, you don't want to be obstructing airways at all. So do not cover those other nostrils. And you can also throw out naloxone once it expires because it isn't a medical toxic, considered, yeah, medically toxic. Does this kind of make sense to folks? Does anyone have any other questions about physically administering naloxone or anything that they would want us to clarify?
One thing you can do to find it's an easy way to just figure out where a muscle is that you can inject is it's for the thigh. You put one hand above the knee, like you're grabbing their leg. And then you put another hand also like widthwise on their leg around their hip, also like you're grabbing their leg. And then the space in between your two hands, you aim for the middle, and there's usually the thigh muscle is there, the quadricep that you can inject into.
Thanks for that, Simon. And a good rule of thumb also is just the top of the thigh, halfway through the middle, right? The muscle is going to be there regardless. Everyone has a muscle there, even if it's small, because I have to do my injections, you know, and I'm not the most buff person. So it's usually pretty easy to find that muscle. And thanks so much for that tip, Simon. Did anyone else have any questions or anything they wanted to add?
So there's so many good questions in the chat right now. Folks are awesome. The question, do we need to squeeze the muscle? It's kind of, yeah, you don't really need to, but it's like, if you're having trouble finding a spot to inject into, I guess, if they have really low musculature, but you don't need to do the injection. And thank you so much, Serena. It should be kept at room temperature, 15 to 25 degrees Celsius, away from the sunlight. Yeah. So I will sometimes put it in like my bathroom sink, like under the sink, because it's coolish there. And in terms of the questions that were answered, I'll just go over them really quickly. You can throw it away in the garbage, 36 months to expire. Doesn't matter if the nostril's covered. The whole vial, oh yes, so do one syringe. So fill the whole syringe, then wait 3 to 5 minutes and administer another one if there's no response. And it doesn't matter if it's up or down. And yes, you can inject through clothing. Zaid can't see the questions.
Yes, thank you so much, Maddie. For some reason, when I am sharing my screen, they won't let me open the Q&A section, only the chat. So maybe, Maddie, if you want to be in charge of questions, that would be great. Cut me off, whatever. I love it. Um, yeah, and thanks so much for asking questions, folks. And those are all super important. And yeah, again, the good thing about intramuscular needles is that the needle is typically long. So you can inject through clothing. You can do some of those things. Easier if you don't, but if you have to, it's also very okay if you do. And just like Maddie said, yeah, each naloxone kit will come with 2 doses. However, if someone is unresponsive after the first dose, you can offer that second dose. And when you run out, you're just able to go to Shoppers or any pharmacy and say that you need a refill on your kit, and they should do that for you.
And also, like when I say 3 to 5 minutes before you administer another one, if they're not responding, that's for intramuscular injection. For nasal spray, if you administer like a full spray and they don't respond, just administer another one straight away. Don't wait 3 to 5 minutes. But 3 to 5 minutes if it's an if it's an intramuscular injection, then you should wait a little bit because it's more it's stronger.
Also, the cutoff in terms of their breathing rate for when you should administer naloxone is generally once it's below 8 breaths a minute is the hard number for. It's like a shallow breathing. Usually it'll be an irregular rate, so you can count the breaths, and if it's below 8, so they should still have some respirations, but they'll just be very shallow, and it'll be a very slow rate. Normal respiration rate for anyone is 12 to 20 breaths a minute. So 8 breaths a minute is significantly lower than that.
Thanks for that, Simon. And again, even if it's below that 8 breath threshold, right? Or if people aren't breathing, it's still worth it in and of itself to try, right? And thank you so much for that low breath threshold. I had no idea that the usual was was 20 breaths per minute. I don't know why that seems so low, but it makes sense. So
well, that would be a pretty fast breath rate, actually. Like that's the high end of normal, and then the normal end would just be it's around 16.
Good to know. That's a good fact. I had no idea. Thank you for that.
Because it's inhale and exhale.
That makes sense. And again, we chatted about this a little bit earlier, but this is just where you can locate naloxone if you're someone who's looking to get a kit. So almost all Shoppers, drug marts, and pharmacies will carry them. However, if you're having trouble, these are 2 services that are kind of doing mobile delivery for naloxone kits right now, because it's COVID. Maybe it's not the most accessible thing, right, to go and walk into a Shoppers. But these services both offer delivery and also vans, depending on like going to meet up at a specific location. So if you're someone who immediately needs a refill on their naloxone, but doesn't feel comfortable kind of going into places publicly, these are really great options. But if you're not someone who feels kind of the COVID anxiety around that, or maybe numbers are lower where you are, they're definitely not low where I am. This website here, the Ontario.ca like government website, has the where to get a free naloxone kit. Oftentimes what will happen when you go to pick up these kits is that folks will ask for your ID and sometimes try to give you a little bit of a runaround, like Maddie was saying, right? You might get invasive questions of like, well, why do you need this? Or what does this look like? Or are you a drug user? And you have the right to absolutely refuse all of those questions. You don't need to answer them to get your kit. And you're very much able to say, I don't feel comfortable answering these questions. Could I just have my kit, please? And you are allowed to deny some of those questions. So just some good info to know surrounding your rights when you're accessing these kits. Did anyone else have anything they wanted to add to that? And good question, Janet. If you can't keep the kit at home, if your family doesn't approve of anyone using, can you keep it in your room? 100% you can keep it in your room. I personally keep it in my backpack in my room just to ensure that it's a dark space, right? When it's in the kit anyway, the kit kind of keeps it a little bit climate controlled. It's by no means a freezer bag or anything like that, right? But you're able to kind of keep it in some of those darker, more private spaces if you need to, because absolutely, it can also be a safety concern, right? If folks in your home don't want you to be having some of those things. Any other questions? Yeah, and just like Maddie said, if people are being judgmental or difficult, just power through. They absolutely shouldn't be doing that. But if you just kind of push, they're not allowed to deny offering you a kit. even if you have several already. Don't tell them you have several already. Stockpile like Maddie does, right? But you can definitely have more than one kit. You can definitely request kits regardless of what your situation looks like. So try not to get intimidated out of getting one of those. Yeah, Maddie.
Yeah, these questions are awesome, folks. Thank you so much. You're terrified of the needle hitting a bone. I know that's really scary. It's not going to happen. If you put it in through the muscle, in the thigh, in the glute, yeah, it's not long enough. It's not going to happen. The most serious thing that can happen with an overdose that you're trying to reverse is that you don't give them the naloxone and they pass away. Like, do not be afraid of giving people naloxone. It is the safest thing you can do. And then in terms of if you're planning to call 911, when would you call? We have more info about the Good Samaritan Act, but call 911 as soon as someone overdoses. I know in safe consumption sites, people don't always call right away because they're more trained with and they have access to oxygen and they can reverse people pretty quickly. But if you are not in a safe consumption site, call 911 immediately before you help them and put the phone on speakerphone, put it on the ground and tell them what you're doing, and then you help them. And you tell them that you don't send police, you just need paramedics and it's an overdose, and they should be doing that. But we have more info about Good Samaritan, and I have more info as well.
Great. Thanks for that, Maddie. And just knowing what the needle length kind of looks like, this is what your average intramuscular needle length is going to be, right? So it's kind of impossible to hit that bone in the sense that you're really only looking at 2 inches of an injectable, of the actual physical needle itself, right? So I know it sounds really scary, and when we talk about intramuscular, you have this like big needle in your mind, but this is actually just the length that it's going to be. Pretty scary and not intimidating. As someone, I take a medication where I have to do intramuscular injections every week, and it also they're not painful, you don't feel them, you're not going to be hurting anybody by doing the injection. So just some things to keep in mind as well, and maybe to ease some of those fears. Now, topic of the conversation, thanks Maddie for kind of leading us into this, but do you want to maybe talk about the Good Samaritan Act?
Yeah, okay, yes. So the Good Samaritan Act, this is the the text of it on the screen. Essentially what it means is if somebody is overdosing, they can't be, if you're calling 911 because of an overdose, when folks come, if the police are coming, because it used to be that police always came on overdose calls, they can't go through your things. They can't go through the person's possessions and find drugs there. But more importantly, they can't be charged with possession of a drug. They can be charged if they already have a warrant out for something else that isn't, it's like you murdered someone and they have it's not like Good Samaritan law is going to protect you if you overdose and but essentially it means that you can't be charged for having illegal drugs or taking illegal drugs if you're overdosing or if you're calling 911 to help somebody who's overdosing. So I've known people who would have been saved by this law, just to be honest, because the people who they were with, they weren't alone when they were using drugs, and the people who they were with were afraid that they would be arrested for dealing drugs if they called 911. So they allowed this person to stay there and overdose and pass away. And that's the ramification. Those are the consequences of fear of the police and criminalization of drugs, which is also something Zaid's going to be talking about. But essentially, don't be afraid. If somebody's overdosing, don't worry that they're going to get in trouble. Don't worry that you're going to get in trouble if you have something on you. Just call 911, say no police, and know that the Good Samaritan law protects you. If the police start going through this person's things anyways, which they do, tell them if you feel up to it, Ontario's Good Samaritan Act protects this person from you going through their things. And they should know that. But if they don't, you can tell them that.
Yeah, for sure. And I think that was an important part, Maddie, that the police, right? We know the way some of these systems work. They'll try to kind of still do these things, right? So much of the time. So I think that what Maddie mentioned was really, really important, that if you feel comfortable and safe being like, hey, actually, this act of legislation protects me. But if you're someone who doesn't necessarily feel safe in addressing that in that moment, right? You still wouldn't be able to be charged or go to court X, Y, and Z because this law is still standing. So if it did even go to a court type situation, which it won't, but if it did, you would still have the law on your side and you still wouldn't be charged with possession or anything like that. Does that make sense? And I see 2 questions in the Q&A. Maddie, do you mind?
Yes. So I just answered Jasdeep's question, just about how long does it take for it to work. It should. So for some folks, it's going to work right away. It depends on what they took, or what was in what they took and how it reacts to naloxone. There are things now that folks are overdosing on that naloxone is not the best solution. It's actually oxygen. But for a lot of the overdoses in Toronto and for the past 5 years, naloxone spray is extremely effective and should always be administered. It should work right away. If after half a minute to a minute, it's not working, just give them another bottle. And then there was another one. If a person is in crisis in their home, but their family doesn't know they're using, what do you tell them if you want to help your friend without outing them? If you have a concern that your friend is using drugs and that their health is in jeopardy, I would recommend talking to your friend directly about it as opposed to going to their family, because outing people can be dangerous for them. And I'm happy to kind of talk to you about that situation if you'd like to, and I can put my number in the WhatsApp. But I would not, unless this person overdosed, talk to their family about it. If you think somebody overdosed and you can't get in contact with them, call 911 and call their family and call everyone. But if that's not what's happening, then it's not a life-saving emergency. If the spray needle works and the person seems fine, should they wait for paramedics anyway? It's kind of up to them. If they're feeling okay, they can just, like, again, if people are administered oxygen and they feel better, they should wait. Like, they should stay sitting down because, as Zaid said, there's probably going to be vomiting. Folks don't feel good after they are administered naloxone. It feels really shitty. So, and I would wait for paramedics because paramedics have oxygen. But they can do whatever they want to if they want to leave. And if the person with the overdose individual, yes, so technically that's the way it works. Even if the person who sold them the drug that led them to overdose is the person who called 911, that is really the purpose of the act, is so that you're doing the right thing and you're calling. And just because you sold something and somebody overdosed doesn't mean you're not going to do the right thing, and you're still going to call so that and you won't be charged. Although if there is a warrant out for you for drug trafficking, then you will be, but otherwise you won't be. Sorry, I hope that answers things.
Thanks for that, Maddie. And yeah, I think that one of the last things that Maddie had touched on was really important surrounding the, like, so many lives have been lost, right, before the Good Samaritan Act had been put into place, right, because of the fear of carcerality, because of the fear of police, because of the inherent racism that we know that situation is going to hold, right, in so many circumstances for so many people. So this policy is actually really, really, really important, and something that was definitely advocated for by harm reduction activists. And I know we've been saying harm reduction a lot, but we haven't really explained what that looks like in its entirety. And so I think that brings us to our next slide, which is just talking a little bit about what is harm reduction, right? So harm reduction is an evidence-based, client-centered approach that seeks to reduce the health and social harms associated with addiction, substance use, without necessarily requiring people who use substances from abstaining or stopping. And I know this kind of confuses folks, that last part sometimes, right? Where we're like, but don't we want people to not be using drugs? Don't we want people to be sober, right? And I think it really comes down to a conversation that we need to have around access to resources, what leads folks to using substances, right? And some of those other things. And we'll get into that as well. But I think a big part of understanding harm reduction is kind of dispelling the myths of healthy and unhealthy coping strategies. And I know that sounds kind of confusing as well, right? So content warning, I'm going to mention suicidality just for this next little part. So oftentimes when we think about coping, right, we see coping, and coping we know to be something that gets you through a really difficult time, right? Oftentimes that difficult time is suicidality. If using substances is the only thing that is keeping that person in this world or in this life, right? Then who are we to say that that's unhealthy? Because is it not healthy in and of itself to stick around in some of those ways, right? What's healthy coping, and who decides what's healthy coping, right? When we know that so many racialized communities, for example, have deep, deep, deep intergenerational trauma, and therapy costs hundreds of dollars an hour, right? And when we put that side by side with hiring discrepancies for racialized people, for example, where are people accessing those services, right? There aren't any. So oftentimes, so many people fall into using substances or using some of these drugs, and we have to have a really honest conversation about what's healthy and what's not healthy, and who are we to decide what is healthy and not healthy for another individual, right? Without knowing their story, without knowing their traumas. That being said, it's also important to recognize that some folks just do drugs because they want to do drugs. You don't have to be someone who has a traumatic experience or trauma to be someone who uses substances. And again, right, that's really about unpacking who we view to be substance users and who we don't view to be substance users, and what lives we deem valuable and what lives we don't. So harm reduction really is kind of that concept that is about reducing harm at every step of the way. We know that it's impossible to eradicate harm, right? There's always going to be harm. There's nothing we can do about that. But why not at every step of the way, right? Try to reduce that harm to an extent. So I talked about this a little bit already, but kind of thinking about in your mind, right? And dispelling that myth of unhealthy and unhealthy coping mechanisms. And a really big part of this is kind of associated with stigma, right? And that's where we see a lot of people losing their lives to overdose as well, right? Because if you're someone who's constantly talking about how drug use is unhealthy or drug use is shameful, one of your friends or your family members, and I promise you, you have a friend or a family member who uses drugs, everyone does, are they going to feel safe and comfortable coming to you if they're in a medical emergency, right? Are they going to feel comfortable and safe disclosing to you? And that could be something where a lot of people and a lot of drug users, because of the stigma surrounding drug use, and kind of the labeling as being unhealthy coping and unruly, will oftentimes overdose without even contacting anyone, without even anyone knowing, right, that they're using substances, because they don't feel comfortable reaching out to the people in their lives, right? Because the stigma is so deeply embedded in all of us. So when we're talking about dispelling kind of healthy and unhealthy coping, it's important for several reasons, right? We just discussed that who are we to decide what's healthy and unhealthy for other people, recognizing that that may be someone's only and best coping strategy for what they're going through in their lives. And also unpacking what this means for you will mean that the people around you will feel more comfortable in reaching out for that support if they need. Yeah, Maddie.
Sorry, so I was just Googling to double check because I wasn't 100% sure. So Good Samaritan Drug Overdose Act actually doesn't technically cover folks who are trafficking controlled substances. So it's supposed to only cover people with simple possession of controlled substances, which actually will make a really big difference. And if folks are trafficking, then they should probably move their stuff and call 911 at the same time, and still call 911. But it doesn't provide legal protection against outstanding warrants, production and trafficking of controlled substances, or all other crimes not outlined within the act. So if you're doing something else that's technically illegal, yeah. But there's a lot of information if you want to Google Good Samaritan Drug Overdose Act, which is a really good thing. And again, if you can't be charged for possession if folks are overdosing.
Thanks for that, Maddie. And I think too, like with the part about if you're trafficking, right, you can face that legal repercussions. And I think it's exactly what you said, where they don't need to know that you're trafficking, right? Because if you're the person who called, they can't necessarily search your belongings. So even if you put your gear in your backpack or put your gear to the side where someone can't see it, they won't have a way of knowing that you're trafficking. So you don't need to like out yourself as the trafficker. Not that I think anyone would, because that's just we use brains. But I think that you're able to kind of hide those things, right? Because there's still that part of the legislation that says that personal items can't be searched, right, as a repercussion to calling that number and to calling 911 if someone is in a position of overdose. So as long as you're hiding your stuff, I think you're okay. And thanks for that clarification, Maddie. So next, I want to talk a little bit about prohibition and safe supply, and why prohibition is not good and why safe supply is good, right? So I'm sure we're all familiar with the concepts of prohibition, right? We saw it first historically when alcohol had been made illegal, as a way of kind of so and so on paper, right, controlling the masses. But we know that when prohibition was actually implemented, not only did it fail drastically because folks were still drinking, but actually it increased to the overall consumption of alcohol. When substances are prohibited, we have this idea of thinking that means it's going to decrease it. But what it actually does is increases the use of that substance, in this case, alcohol. But if we look at prohibition in a modern day sense, right, with illegalized drugs, it's kind of the same concepts. And when we look at how drug legislation is passed in the modern day, they oftentimes use prohibition as a framework, which doesn't really make any sense because we know that it failed so drastically, right? So not only did prohibition make people drink more, but it also failed to decrease the taxpayer burden, which was one of the big reasons why they had put prohibition in place in the first place. Where it was kind of the idea that taxpayers would have to pay for all of these various things if they were broken because people were using alcohol, which that's not why things are being broken. They realized pretty quickly after they had put prohibition in place. So it was really good for nothing. It also increased prison populations, right? Because then you're criminalizing something. So therefore, there's going to be more people incarcerated, and public corruption. So clearly there was no easement on the burden of taxpayers also, right? Because you're increasing the prison population, which tax dollars go into. And I know it always sounds like conservative and weird to tie things back to taxes, but oftentimes when we think about these are kind of the talking points, right, that more conservative folks kind of bring up, where it's like, well, but prohibition is good because then we don't have to fund safe injection sites because that's where taxpayer money goes, or fund health services or rehabilitation centers. But realistically, it's actually even more burdensome on tax dollars, right, when we're criminalizing substances because there's more people who are ending up incarcerated. And prohibition kind of founded and laid the groundwork for the modern day war on drugs that we see now. A really important backstory around prohibition that a lot of folks maybe don't know is that when we kind of read about prohibition, right, in a lot of our history books, we read about it as a way of like people were seeing that alcohol was bad and didn't want it in their societies. But a lot of historians, and I can find some sources on this after if folks are interested, prohibition was actually implemented and advocated for by white women who were uncomfortable that their husbands were drinking and hanging out with racialized men, namely Black freedmen, Indigenous men, and East Asian men, and specifically Chinese men who had come for railway services and things like that, right? And that was actually the reason why prohibition was put forward, because people were uncomfortable that white people were starting to engage more freely and socialize with their racialized counterparts, right? And that was making white America and white Western world really uncomfortable. And specifically, that led the cause for white women to start advocating for prohibition. So when we kind of know that that's the racist backstory and blooming of prohibition, it becomes really easy to see, right, how prohibition founded the war on drugs, which we already know to be deeply racist. So the war on drugs kind of kicked off in 1971. The Reagan era was like super stoked on the war on drugs. And we see the same failures of prohibition coming along with the same failures of the war on drugs, right? Because it's basically the same concept, just rebranded. So the war on drugs started in 1971. It is now 4 decades old, and there has been no improvement in folks in decreasing drug use and decreasing folks who require rehabilitative services. No difference at all in folks who are using drugs. It has increased the cost to the taxpayer, actually $1 trillion over the past 4 decades, because a ridiculous amount of government services, both in Canada and the US, go towards the war on drugs, which means essentially coming up with anti-drug legislation, anti-drug programming, right? And all of the things that we kind of would associate with kind of the fight against drugs, right? And tons of policing, exactly, Maddie, tons and tons of policing. And when we look at actually the percentage of folks who are incarcerated, majority of the people in Canada and the US are incarcerated for drug-related offenses. And people sometimes think that this is a solution, right? Because if someone's locked up, they won't be able to access services or access drugs. I'm telling you, as someone who is incarcerated myself, it is much, much, much easier to access drugs in a prison system or in a carceral system than it is in the outside world. Also much cheaper. So it's actually not the case. So what we do is we kind of trap people in this cycle, right? Because we're locking them up in a space where they're not able to get the support they need. But also after they exit the carceral system, we know that people who have criminal records aren't able to be employed, right? Most jobs do criminal record checks. So then what do people have to do to get their income? Folks oftentimes go to selling drugs, right? To kind of make up for the fact that they're not able to get a job now because of that carcerality in the first place. So the war on drugs not only fails as a prohibitionary method, but it also continues the cycle and actually funds the drug industry, right? So as we know, the war on drugs also ignores the root of the problem and what leads most people to using substances in the first place, which we know is a lack of jobs, intergenerational trauma, cost of therapy, right? All of these different things. And when we are just focused on criminalizing, right, we're still criminalizing racialized people, Indigenous people, Black people for not being able to access the services that they need, right? Incarceration is obviously a huge part of the war on drugs. And if we look at who's like the percentage of folks who are incarcerated, right, for substances, it's usually about approximately a little bit over 70% of inmates in Canadian prisons are actually incarcerated for drug-related offenses. So non-violent drug-related offenses, right? And why should we be criminalizing people for that? Which becomes extra evident, right, when we talk about the disparities of who is incarcerated and who's not incarcerated. So we know that of the women prison population in Canada, 42% of incarcerated women are Indigenous, right? But we know that Indigenous women only make up 0.2% of the Canadian population. So again, when we look at those kind of disparities, we know, right, you can start to see how the war on drugs is inherently racist when we know that majority of people who are incarcerated are there for drug offenses, and the majority of people incarcerated are Black and Indigenous people on these lands, right? The war on drugs also instituted the 3 strikes rule, which was an American piece of legislation that was put forward by Bill Clinton. But it essentially was the idea, sorry, I always have to throw Bill Clinton's name in there, was the idea that in America, in several states, specifically for drugs as well, that if you are caught doing the same crime 3 times, it is a year in prison, right? And when we know that Indigenous and Black and Latinx people are surveilled by the police and constantly getting stopped and frisked down and pat downs, right? If you're caught with 1 joint on you 3 times, that's a year. That's sorry, not a year. That is a lifetime in prison. You will not have chance for parole. You will never see a day of your life outside of a prison cell again. It's not even like this many years with a chance of parole. No, you're done. 3 strikes, you're out, which was literally why they called it 3 strikes, which I think is so disgusting. Like, I think that really, again, kind of shows the lack of care that we have, right? So we have people who are in jail for hundreds of years, essentially, for lifetime sentences for having a joint on them 3 times versus people going to and being incarcerated for sexual violence, right, for periods of 2 months. Not that I advocate for anyone to be incarcerated. I'm very much an abolitionist, right? But when we kind of compare some of those rates, right, how is that making any sense? And exactly, Maddie, there are still people serving life sentences in the United States today because of the 3 strikes rule, right? So you see a generation of racialized fathers, mothers, parents, and individuals, because again, people's worth doesn't depend on their role to other people, right? Being incarcerated, right, for the smallest things. And even if, as we move towards the legalization of weed in Canada, right, there are still people in Canadian prisons serving sentences for marijuana possession, right, and for weed possession, even though Justin Trudeau promised he would pardon them, right? And we still haven't seen everyone pardoned. And I'm sure you can imagine who is getting those pardons, right? And who is not getting those pardons again, right? We're seeing Black and Indigenous men specifically incarcerated for years and years and years for something that is not even a crime anymore, right? When we know that police officers themselves are opening dispensaries, the same police officers that incarcerated these people to begin with. Don't go to the dispensary in Kensington Market. It's owned by a cop who spent his whole life incarcerating people for drugs. Don't go. And the last two things that the war on drugs kind of instituted, right, is no knock warrants. And this is what we saw in the case of Breonna Taylor, right, in the United States, where if you're someone who is considered to be a drug trafficker, so someone who is selling drugs, which also like drug trafficking just sounds, it makes it seem so much more serious. Like you're just selling drugs, you're just a drug dealer, like chill, you know what I mean? But when we see these no knock warrants, right, if the idea is that you're a drug trafficker or a drug dealer, the police are able to just burst into your home unannounced. I'm not sure about you, but if someone's bursting into my home unannounced, like I'm going to be scared. I'm going to have a reaction. How is that fair, right? So people are able to just kind of do that as well. And that is, again, another piece of American legislation. And as I'm talking about a lot of these things, we'll notice that they're American, right? But Canada very much models its justice system after America. So although these systems are inherently American, right, we see similar pieces in our own legislation. Another thing that the war on drugs actually implemented, and I know we talk about carding a lot, but the war on drugs was actually one of the first times carding was introduced in both America and Canada. So because it was the idea that racialized people were, of course, using drugs more frequently, or that Latinx folks are responsible for all drug trafficking and all these racist stereotypes that we see, allowed for the process of carding, right? Which we know is a deeply racist system where the police are able to just stop anyone on the street they want, request ID, and oftentimes put it in the system. So even if you didn't commit a crime, right, you're still known in a police database, which is going to make your life harder. One of the things that when we talk about prohibition and when we talk about the war on drugs, people have this idea that like, okay, well, I'm sure like it's at least like decreasing the price, increasing the price of heroin because it's making it more difficult to access, right? When we make things prohibited, they should be more expensive. And again, if we look at this chart that's on the right-hand side of this slide here, right? We can see that in 1982, the price of a pure gram of heroin was around $2,000. And by 2006, it was below the $500 mark, right? And this is with strict drug policy. So again, you can't even make the argument that prohibiting things makes them harder to access, whether it be for price or availability, because we know that that's fundamentally not the case. And yeah, exactly what you were saying, Maddie, with carding, it's super traumatizing for people, and they do it in Toronto, and there's been several exposés done about the Toronto police and carding specifically. And the no-knocks, yeah, they also do in Toronto. And oftentimes when they get called out for it, they're like, yeah, we know it's not technically allowed, but people are still doing it. So like, as we know, the police have their own set of rules the laws aren't always the most followed. That's my personal opinion. We can talk about that more later if folks want. It's also important that when we kind of talk about the war on drugs and what this has looked like, the idea has been, again, right, and kind of the argument that we see from conservatives or Republicans or whoever it may be, not to say that the liberals or other parties are on side with drug reform and legalization either, because they aren't. I won't pretend that that's the case. Right, but the kind of idea is that if we're making something prohibited and illegal, it'll make it it'll make it more expensive and it'll make it used less. As we saw from the last graph, we know that the price has gone down drastically, but also drug use has stayed pretty similar, right? You see some dips for a little bit, and then you see it kind of go back up and stay pretty stagnant, right? Going between 20 and 40%, actually not a huge difference, right? So if we're seeing the numbers kind of stay the same and actually even go back up again after 95, right? We know again that this doesn't work, right? That the idea of prohibition and the idea of criminalizing drugs doesn't achieve any of the goals, even if you're someone who doesn't want someone to be using substances, right? So from either sides of the spectrum, we know that prohibition and the war on drugs actually isn't effective at all. The only time I can think someone thinking it's effective is if they're like, I support racism and I want someone to be incarcerated. Because again, that's the only thing that we've seen, right, come out of this process. This is another chart, and I apologize. It's not like the clearest or most crisp chart, you know? But when we look at some of the last graphs that we saw, right? And then we look at the graph of who's incarcerated, right? The only huge shift we've seen since the war on drugs is in the number of people incarcerated. That's literally the only big drastic shift that we've seen. So if you look around 1971, when President Richard Nixon declared a war on drugs and kind of started the war on drugs, which he did before an election year, fun fact, so we could get more votes from anxious white Americans. But right, when we kind of look at when this was imposed, we see that the number of incarcerated Americans was around 50,000 people. In 1984, the Sentencing Reform Act came into play, and that's when we started to see drug criminalization be much more dramatic. Because when the war on drugs kind of kicked off, it was mainly just like Richard Nixon and then his party being like, don't do drugs, kids. And then 1984, they were like, clearly this isn't working. Let's make this a little bit more intense. And that's when they put in sentencing reform that increased prison sentences and increased criminalized sentences for folks who carry and use drugs. Right. So after we see 1984, that number drastically skyrockets to above to the 2 million mark, right? Like the 2,500,000 mark. I'm not good at math. I'm pretty sure that's what that number is. Please correct me if I'm wrong. But we see these numbers extremely drastically increase, right? And again, we know that who's being incarcerated. We know that it's racialized people being incarcerated. And America, fun fact, actually has more incarcerated people per capita than anywhere else in the world, period. There's more inmates in America than any other country in the world. And we see this play out, and only after drug reform, right? So that's a huge burden to the taxpayers. That's a huge burden to so many various things, but of course, furthering racism, right? And furthering that segregation. So really important to kind of keep that in mind too. When we talk about prohibition being used now, what has that actually upheld in our justice systems? And fun fact, there are actually more American people incarcerated than there are in post-secondary education. So we talked about why prohibition is bad, right? But why should we be moving towards safe supply? So kind of when we talk about safe supply, the idea is always that, well, but if we offer a supply or if we're offering folks drugs, the number of overdoses is going to be so much higher and so much more incremental. And the idea that people are dying from overdose, kind of people have this very skewed number in their head, right? So when we talk about things that are dangerous, more people die from pharmaceuticals, for example, per year than people die from drug overdose. But we don't see prohibition on pharmaceuticals, right? Even though we should, because pharmaceuticals did start the opioid crisis, right? We see 30,000 people die from automobile accidents a year, right? But no one is saying that we should make cars illegal or that we should prohibit cars or criminalize drivers, right? We see 38,000 people a year die from excessive alcohol use. But again, alcohol is legal, right? And then when we talk about from overdose, we're seeing those numbers within the 4,400 mark within Canada per year, which I think is honestly a very low ball. I think the number is probably a little bit higher than that because we know that so many people don't have the supports to be able to reach out when that is a process that is happening to them. So when we kind of talk about safe supply, right, again, that argument is why should we be supplying something that's deadly, right? But we see here, and when we look at these numbers, that there are things that are much more deadly in our day-to-day society, but we don't criminalize them, right? Because we can't stigmatize them. And because they're not things that we see as undesirable people using or doing. So safe supply has saved thousands and thousands of lives since it was introduced. And there's lots of amazing harm reductions in Toronto, for example, the Moss Park Safe Injection Site, and all of these different services. And oftentimes with safe supply, and what safe supply is, sorry, for folks who don't know, is providing a space. So it's partially safe injection sites, so providing a space for people to do drugs around nurses and around folks to make sure that they're safe if something does happen. But safe supply is also providing drugs to folks who are users that are safe, that aren't tainted, right, that aren't laced with something and that have been tested to be safe, right? Because oftentimes, because we have this criminalization mind about substances, so many people don't have access to things like safe drug testing kits, right? Even though those are lifesavers. People don't have access to ways of testing their drugs to know that if they're laced with something to begin with. So safe supply is really, really, really important because we know that people are going to use drugs. People have used drugs throughout human history, right? Since the invention of people themselves, right? People aren't going to stop doing drugs. So why, instead of criminalizing it and making it harder and making people get drugs from services that could be tainted or could be laced with things, why not supply folks what they need in the meantime so they can be safe while they're working through whatever they're working through, or while they're doing what they want to do? Because sometimes folks just want to do drugs, and that's also okay, and a realization that we have to come to as well. It may not be our path or someone's path, right? But that doesn't mean we have to agree with it. But if that's what someone is choosing, that's what someone's choosing. And we should respect that choice the same way we would respect any other choice, right? So that's some of the reasons why safe supply is incredibly, incredibly, incredibly important. And what we're seeing now, and what we see with majority of overdoses, is actually accidental overdoses from folks' drugs being laced with either fentanyl or various opioids that they didn't actually know were in the drug themselves. So again, safe supply is decreasing those number of overdoses because we know that these are tested, right? There's been folks who have overdosed on weed because it's been laced with fentanyl, right? So even substances that we consider to be more safe, there's always that risk. So safe supply is really important for that reason as well. And thanks, Maddie, for including that part too. Going back to the 1984 was an election year maneuver by Clinton. Yeah, and that's when they started to talk about the 3 strikes rule even more seriously and kind of start to implement some of those policies. So where do we go from here, right? We've kind of talked about why prohibition is bad. We know that criminalizing drugs isn't good and only leads to bad things, right? We know kind of that safe injection sites are important. So what can we do, right? And I think some of the things that we can do and tangible steps that we can take is locating where you can get drug testing kits in your city. Even if you're not someone who uses drugs, right? I will get drug testing kits and provide them to my friends, to my siblings. My little sister just started university. People are going to use drugs. It's first year university, you know, but what can I do to make her safer, right? I can provide her with those testing kits. And you can get these different kits and order them from a lot of different community organizations in Toronto. I will try to make a list and send it out to the folks who attended so folks kind of know where to access those. You can supply harm reduction tools at your students union, right? So if that looks like if you're a students union rep, or if you're someone who is looking to get involved, or someone from another campus even, those are some of the things that we can do, right? And some of the things that Caesar is going to be trying to do as well. Making sure that you know where the needle disposal centers are on campus. Ryerson actually has a needle disposal needle disposal spaces in the student center and all of the student center bathrooms and some other places on campus as well. It was a fight to try to get those on campus for sure. Admin definitely pushed back against some of those wants, right? But knowing where those are in our campus. And I think Ryerson is really, really specific, and Chang School, right, is really specific because we have a safe injection, not a safe injection site, but a public health safe injection site, right? Like basically on campus at that corner right beside Victoria Building, right? And we've seen students and profs and admin react to folks who use that space in really, really harmful ways, right? We saw that with the implementation of the planters beside Tim Hortons. So folks who were using those services wouldn't have a place to sit or lay down or sleep, right? And we have these conversations on campus in a really harmful way a lot of the time. So it's important to know kind of this background. So when you see other students or profs or admin kind of talking about some of these things, right, you have the information to be like, wait, we need these services. It's actually a gift that we have one of these services so close, basically on campus. Locating the safe injection sites near you is also something that's important to do. So if one of your friends or community members or you is looking for a safe injection site, knowing where they are, right? So if someone asks, you have that information on hand. Question the ways we think about people who use drugs. And this is, I think, a big one, right? Because we have this really weird idea that folks who use drugs are like, look a specific way or are houseless or X, Y, and Z, when like, I promise you that like your profs are using drugs, right? Your parents, maybe even your family members, your cousins, your friends, anyone can be a drug user. There's no way of identifying who's a drug user, right? So when we destigmatize the ways we think about people who use drugs, it also becomes a lot easier to kind of push for that legislation, right? Because it's no longer about, oh, we don't think drug users deserve our place in the society because they're a certain way or look a certain way. But you're advocating for everybody when you're advocating for harm reduction. And very true, Maddie. Yeah, absolutely. Alcohol is a drug too, right? Coffee is also a drug. So like when we talk about who's a drug user, why are some drugs good and some drugs bad, right? Why is it okay to get an opioid and use opioids from a pharmaceutical or from your doctor, but if you're using it personally at home, that's not okay, right? So questioning the ways we've been taught to kind of think about these things. Destigmatizing our language, right? So if that's like the popular slang that was going around for a while, that's like, oh, you're such a crackhead. Like, no, because what does that mean, right? Like, one, is just gross. But like, two, what are we saying when we're saying someone's acting like a crackhead, or what are we saying when someone's acting like a drug user, right? And fighting for the legalization of all drugs. And I know this is a big one and a scary one for some folks because they're like, but what does that mean? But I think, right, as we kind of went through that language and went through kind of the history of prohibition and what the war on drugs has meant, yeah, and I know when we're talking about the fight for legalization of all drugs, it can be kind of intimidating, right? Or people are like kind of stressed about that. But something that's important to think about is that we know that after learning all of these different things, learning about the racism, learning about prohibition, that legalizing all drugs really is the only and best way forward, right? Why criminalize people for something when we can be offering the support that folks need? X, Y, and Z, right? So I think that that kind of ends us up for today, but I'm going to pass it off to Maddie to kind of wrap us up with some last bits.
Yes, thank you, folks. And thank you so much, Sade. This was amazing and super, super valuable. So folks, this will also be available, this video, on Caesar's Facebook. If you want to check it out or send it to anybody, please do that. And also please contact Sade for your harm reduction workshops.